Kia ora. That's as far as I go in Maori. Sorry about that. But I can do this. You can see me now. Now you can't. So I'm gonna walk around here and just try to sort of send you to sleep. I won't get offended if you sleep because I'm going to talk about numbers and things and a bit of statistics. You can either start now or when I hit the curves and all the numbers. So it's, and I forgot what I was going to say. Anyway, as Phyllis said, Mike, I'm Sayed, and I noticed she didn't go any further than that. It's Shahtahmasebi, for those of you who've been asking me. I'm originally from Iran, Persia, not to be confused with Iraq, which is, Iraq is on the news every day. But I left, for those of you who are young enough to remember, when the Shah was still in power. I was 16 when I left, 17. I went to England for 3-4 years to do a degree, and that 3-4 years became 5 and 6, and wife and children, and the war started, and my father wouldn't want me to go back because I was responsible for my family, and continued. And later on, I ended up in New Zealand, and we live in New Zealand now. I live in Christchurch, but work in Hamilton. So I know my talk is going to go over time, so I won't tell you any more about me, starting with the... first of all, it's been very interesting past couple of days. There have been lots of fine words, buzzwords, and what have you. A lot of food for thought. But here's another. How does the laser work on this? The pointer. Oh, there. After decades of persisting with the same ideas about suicide and persisting with the same policies, and surely we're entitled to expect a drop in suicide, a consistent drop over the years, however small, instead of the up and down cycles of suicide rates. Oh, how did it go to this star? I didn't press anything. Oh, is it on automatic? Don't touch anything. Anyway, the more I think about suicide, the more I study it and the more I research it. I better keep an eye on the slides. The more I realize and I understood that we really don't understand suicide. We don't know anything about suicide. I don't claim to be an expert. I don't claim to understand suicide, and I always claim that I don't know what causes suicide. So, I don't speak Maori, and I don't know anything about suicide. What the hell am I doing here? It's his fault. Oh, for the car. But I'm going to take you on a journey. I share my experiences with you of attempting to understand and do something about suicide prevention. So hopefully, this will give you an out-of-body experience. In the oh, who was that? In the sense that you'll be looking down and see a bird's eye view. You have a wider vision of what's going on in our societies. It won't be three-dimensional, but hopefully some of it you say, I recognize that one. I've been there. Or you might say, oh, I disagree with what he says. But along the way, hopefully there'll be something that we all share or we have in common. So I did. Where is it going? Am I going back? Oh, there. So I'd like to start with how I got involved with suicide research. In 1996, the Leeds Community and Mental Health NHS Trust, they brought me in to help with capacity building of colleagues to do quality research. You know, it was the decade of evidence-based practice, and everybody was at it. So inevitably, having a mental health unit there, it was inevitable to come across suicide, at least suicide figures and numbers. So for the first time, we collected data from, not just from the records in the hospital, but also we went all the way back to the coroner's records and started from them collecting as much data as possible from social databases, educational, justice, police and all those things, and to build a profile about the cases that went through the hospital and committed suicide. And again, don't forget that all these cases received psychiatric services and went through the mental hospital. So it's inevitable that you take it for granted that, well, it's an easy, it's a straightforward job. You tabulate the data, mental illness, suicide, there you go. But I was intrigued. I'll show you now why. There. Looking at the data, if you look at the top, depression, whether as a diagnosis or mentioned anywhere in the record about the subject, only 17%. And fast forward down to the bottom of the table, and you see that no diagnosis or none recorded, that there was nothing at all, 33%. Now you can imagine how intrigued I was. It was a shock to the system because I didn't know anything about suicide till then, other than what was in the media. And so what I did was I put this in the context of all the suicide cases in Leeds, and it transpired that the cases that went through the hospital formed under a third of all the completed suicides. Then I was even more intrigued then, where does the link between depression and mental illness and suicide come from if we don't know anything about these majority of the cases who committed suicide? Because these two-thirds, they didn't have any contact with the health services, psychiatric services. And we really don't know anything about them. And the process of attempting to share this with colleagues and at face value, it was okay, but trying to publish it, it proved insightful and really enlightening, or call it politics. So quickly fast forward to, it does it itself. Fast forward to 3-4 years later in New Zealand, and I experienced the same thing. I mean, New Zealand has a high rate of suicide, amongst one of the highest, and I've learned that suicide is highly politicized, suicide prevention. But suicide is often referred to as a public health concern. In reality, it's dealt with under mental illness. In New Zealand, as you probably know, and some of you have told me already, and New Zealand's approach has been silence, don't talk about it, and a one-dimensional, flat interventionist approach. A lot of you will remember the guidelines for suicide prevention, which says look for signs and refer to mental health services. To me, that's a recipe for more of the same. Waiting for signs to develop is no prevention. By the time you detect signs, an event has occurred, so it's time for intervention. This approach ignores the majority who don't exhibit the signs or the symptoms. They don't have them, or they're very good at hiding them. And as I said earlier, 2/3 of the suicide cases, and later studies also suggest that it's actually up to 3/4 of the cases, don't come into contact with mental health services. And the approach, the suicide prevention approach, the current approach, reinforces the taboo status of suicide and mental illness. It's changed now. Come on. I'm doing the wrong one. Okay. Along the way on my journey, I also learned that there are lots of groups, medical modelists, social, religious, self-help groups, Maori, Pacific, but we don't talk to each other. It's frustrating. We don't talk to each other. But even more so, possibly because each of us developed our belief in our particular views, which is based on particular experiences. Also, these researchers refuse to share data, especially those who've been funded by public money. There should be something about you're funded with public money, the research should be made available to other researchers. And I found it frustrating that some Maori researchers, academics, don't even communicate. I mean, academia has its own protocol. The idea is sharing knowledge. I find that frustrating. The other thing worse than that is key medical journals that supposedly the experts and the government and policymakers supposed to be consulting are only interested in medical views of suicide. For the rest of the talk, I use official data so that if in doubt, don't blame me, blame the government. This is the time for some of you who want to go to sleep, that's why. I had more, but I took them out. But this suffices to say that this is the best way of displaying suicide rates because it's over a long period of time, and you can clearly see some of the patterns. You can see these cycles. Oops, go back. Cycles, about maybe at least 5 to 10 years, go up and down. And what happens usually, the experts concentrate on a short term. They're interested in that, where the cycle is downturn. They're not interested in that, because it's going up. But also, looking at this, you can see maybe a bigger cycle, a 70-year cycle, So it's cycle within cycle. But let's look at this a bit more closely. It's a bit messy, but it does demonstrate the point. You can see this is by age. You can see there is all of these age groups, they have their own cycles. But what's different is that there is a lagging effect. Some start going up few years after the younger ones, for example. And also, you can see that the older ones, when the cycle is in a brow position, for the younger ones, is a trough. So it's a mirror image. And also when when the trend for the young ones is going up, for the older ones is going down. But overall, you can see that for the older ones, the trend is downward, the long-term trend, and for the young one is upward. It's such a way that eventually in 1987, I think it is, they cross over. And it just demonstrates that we haven't been able to do anything here. Even though there are patterns, we haven't been able to break the cycles, to keep it going down. And these patterns usually demonstrate the series has a memory, and memory, obviously, patterns. And it means that along the way here, these patterns due to something that we do or we don't do. Maybe it's social policy, economic policy, health policy at higher level, and at social level and individual level, other things that we do or we don't do, individual characteristics. Quickly going back to the information provided by the graph, the useful information that should have been informing the process of policy making. But instead, how do we use it? This is how it's been used since I've been in New Zealand. When the trend is going down, hey, hallelujah, our policy is working. Give us more money to apply the same policies to the other groups whose suicide trend is upward. And when the trend is upward, oh well, suicide is very complex. Lots of factors, risk factors, and mental illness. Give us more money to research all this. So basically what we've been given is more of the same. Is that the correct? Yeah. Along my journey, I don't know what to call these. They're not really milestones, but maybe stumbling blocks or adventures. One of them is depression, which you all have come across. For me, the statements here, you've all seen it, 80 to 90% of suicide cases had depression. And going back to the table I showed you earlier, I always question that. Where is the evidence? In fact, this statement, 80 to 90% of all suicide cases had depression, was used in 2006 by the government to allocate 6.4 million to suicide prevention to be used on depression. That's fine. We do need a good mental health service, a good support for depression, but that's not suicide prevention. So this statement, anyway, is based on flawed research. It's not me who says that. Well, I've been saying it for ages, but I've discovered there's references at the end. Australian colleagues are challenging this, and European colleagues also challenging this statement. But for now, assume that, okay, there's nothing wrong with the research. Government's documents state that between 1997 and 2005, antidepressant prescription doubled. And since 2005 to 2012, it doubled again. So by 2013, antidepressant prescription must have over quadrupled. So what happened to suicide rates over this period? Went cycle after cycle, upward trend. In fact, there were 540 deaths due to suicide in 2007, which went up to 558 in 2011. So it's really no-brainer. The other one that I've come across and had to deal with is talking about suicide causes more suicide. There's never been really any evidence to prove this or to support it. I've chosen this particular study because it's been quoted as the most conclusive study for this statement. Now, the studies state that between 84 and 87, suicide rate increased using the subway as a method of suicide. And the study goes on further to say that in 1987, researchers and media got together and decided not to report graphic description of suicides that used subway. And as a direct result, they claimed that the suicide rate dropped by a massive 75%. And as I said, they've been referred to as the most conclusive study. Now, I used the same data to challenge this statement. Here it is. The 75% based on this graph, I assume that it was referring to not suicide rate, but for the number of people who used subway as a means of suicide. But it's well documented that people do switch between methods. And looking at that graph, suicide rate was on its way up before 1984 anyway. And then maybe it's probably better more in this one. And you can see that downturn in suicide rate began in 1985, 2 years before the researchers got together and came up with the embargo. Again, trying to share this with colleagues was very enlightening. But it's been published. This paper has been published. Top journals. Where the decision makers and experts supposed to be consulting, not interested. In fact, I did an experiment. I wrote a piece and submitted it to 5, 6, or 7, so many top journals in the field. And within 2 days, I got a very polite email saying that the readership is more interested in, meta-analysis and longitudinal studies, so they won't be pursuing with this article, as interesting as it is. So I thought that was very polite. But along the way, I also discovered, as I said, other colleagues have different strategies for publishing their work. Some of them target the low-impact journals. The German Medical Journal and Singapore was mentioned several times. And again, I discovered that there are many different alternative views and groups. And again, to the delight of medical modelists, we don't talk, we don't share, we don't collaborate. In 2011, some of you will remember this, the former chief coroner released a statement in which he said the current techniques are not working and we really need new approach. And then he also hinted at gentle opening up of the media for careers in discussion and talking about suicide. That was very bold of him, but there's been many statements like that before, and in my experience, mostly they been used to refocus or focus on the same thing, more intervention, or more ideas that involve, recycling the same ideas. I've never seen anything on prevention. Right? But the judge was severely criticized by proponents of silence without any evidence or with poor evidence and nothing to show any new ideas or any new alternatives. So the offer was more of the same. Again, to demonstrate how deeply this embedded in the public mindset, this real link between mental illness and depression with suicide. Here is a families commission. Here they state that families and whānau have a critical role to play in preventing suicide. It's very good. Yeah, makes sense, yes? But then here they say, I don't know if you can see, it looks blurred from here. I look at the screen. They say, factors contributing to suicide are numerous and complex. We do not really know why New Zealand's rates are comparatively high, but we do know what helps to prevent it. Duh. And then you know what they mean by that, because here they refer to more of the same, and even more of the same, more of the same. So, again, along my journey in New Zealand, it was inevitable not to come across Maori suicide. As most of you know, and some of you have told me, and my research suggests, suicide in Maori is very rare, or was very rare, or even are heard of before colonization. Yes? Certainly it was very low since the record began, and even it jumped itself, so I'll show you the data. You can see the red line is the adolescent suicide. And 1948, when it started, it was below 5 all the way. You have spike there, spike there, spike there, but it's several years in between each spike, but still under 5. 1 is too many, but nevertheless, we're talking low numbers. What happened here? And then here's the spike. This one should have been taken note of. But you can say, okay, his past experience suggests maybe it was just a spike. But soon after, it goes and hit 5. There. And it stays on 5. That should have been, bells should have been ringing. But, okay. And then again, it stays on 5. It did go down and then up again within short, a year, pretty short notice. and then it goes, again it hits 5, and then it goes down. This bit, somebody should have done something. Nothing happened, and then it went up. And when it went up with a vengeance. It just went up and stayed up. Now, this is in 1995, the definition of ethnicity was changed. So it had an impact on the numbers of Maori suicide. So you can see this green one is now adolescent suicide. And you can see how high it is. And it stayed, go back. And it stayed high. Okay. To an outsider like me, I found Maori is very special. You have your own cultural, social, political structures and protocols. But to me, most of the protocols are designed, I can see it, to protect and prevent. So I find this unacceptable to apply mainstream remedies or methods to Maori, or train Maori in the method of mainstream and call it Maori intervention. I really believe in that, because we have the same thing back home, similar things. And, times have changed, and bigger powers have taken control and changed things for us, and it's not on. Okay, so we go to the next one. So what's the solution? What do we do? I don't know, at some point in my journey, whether it was when I saw that first table or later on, that I realized one of my background is sort of problem solving. I studied operational research, which is all about problem solving, but it's about using mathematical models. But the concept is there. So the basic of problem solving is that we really need to understand the problem before we can do anything about it. We do not understand suicide. Well, I don't. And the problem may not be suicide per se, but if you think about it, suicide is committed at the center of each suicide is a person. And that person is connected at the center of a family, community, neighborhood, societies. So we are really talking about human behavior. Yes? So prevention must be holistic. So my thinking was that, okay, we don't understand suicide, but human behavior is better understood in the literature. There's lots of publication in the literature about human behavior. So we do understand when we can do something about human behavior. So any approach then must provide up-to-date information accessible to communities, individuals, anybody who's interested. It must empower communities to own the problem and therefore own the solution. But such ideas, as I can hear from your comments and giggles, that such ideas have as much chance as ice in hell to be funded by major players or supported. So what do? I say, all is not lost. We can do something about this. And how do we do it? Grassroots. The way to do it, empower the grassroots to take control. Oh, So grassroots really is about individuals, about informal structures such as neighborhoods, families, communities, and formal communities and structures such as education, health services, mental health services. With grassroots, we don't discriminate. We don't say, you mental health people, you've been doing us harm, you're not included. Everybody's included. Like Mike King said, what works for you, that's okay, even though it may not work for the other guy. So we find something else for that other guy. So it's all about that. But please do not confuse grassroots approach with other grassroots that you've had. Some of them, including that one that I saw on the internet, was based in the UK. They talk about going and training grassroots in the method of the mainstream and medical model, and then ask them to apply them to the community and call it a grassroots approach. It's not the same thing as this grassroots approach. This is how we did it. Some of you come to our workshops since 2010. We started in 2010 with no money. I've been trying to get this thing off the ground since 2002. I even met Jim Anderton in 2006 several times. Nothing came out of that. Lots of politicians' promises. But so eventually, we did it on our own budget, and a few people got together, and with the help of my manager at the time, she said, Said, this is a good idea. You go for it, I'll find the money. And we didn't need much. We only needed some money to bring Professor Omar, with whom I've been collaborating to develop some workshop training workshops. Because we did a survey of some of the frontline workers, and what the message that came across was that they in desperate need of information, quality information about suicide. They don't know anything about suicide, especially youth. Sit down, I will finish. Sit down. Yes, so they said people come to them, mention suicide, and we all go into shells. What do we do? What do we say? We're going to upset them or make the situation worse. So we developed training workshops, and we went to the communities. We took the training workshops into the communities for free. And it did work. People who came to the workshop, they went back to their communities, took the information, developed their own suicide prevention groups, and started action. So it was time for action, no more talk. And a lot of them who knew their communities, and the idea of grassroots is that the grassroots know their community better than you and I or the government or the experts. And so that's how it works. So all the activities that they develop, they differ between groups. Some went for lobbying the government, some went for actually doing something, suicide awareness campaigns and doing activities that involve people linking with their neighbors, their friends, basically engaging the community and talk about suicide. And yes, a bit of that as well, groups uniting together. So I rush it now because of Michael. You can blame him now. But if you're interested, you come and talk to me afterwards. Again, community involvement, lots of talking, local newspaper getting involved and publishing, keeping suicide alive in terms of talking about it on the agenda. So some of the results in the participating communities, suicide dropped considerably. In some, it's Calder, in South Waikato, they told me they had one youth suicide per month, at least, before the workshops, and it dropped to 0. And I think for the whole period of 2011 to 2015, there may have been up to 4. I'm not quite sure on that figures, but it's very low. So the method is cheap, is adaptable, is sustainable, and it really is local leadership and local action. But there is no room for complacency. Just because your suicide rates drop, you can't take your eyes off it. You must maintain the leadership, the dynamics of the groups and the leadership. So quickly running that. So the next logical step was to formulate this training and provide it nationally. To do that, the idea was I wanted it to be free. I wanted the grassroots to be able to come for free for the training. So we needed a little bit of funding. Despite local supports and community supports and some local charity money, nothing from major players. And some even went out of their way to. But again, not all is not lost, because you can't keep a good thing down. It grows. So what we did was I dedicated the whole issue of the journal to suicide prevention. So if anybody interested, go to this link and scroll down to issue 4, and you'll see all the articles about suicide prevention, including an interview with Judge McLean. So for me, at this point in my journey, I'm confident. I am grateful to all the people who helped me along that, and I've realized that we do have the power to say no to more of the same. And in conclusion, I leave that to you.